Welcome to AETCM, the emergency medicine channel. Today let us discuss about syncope, one of the most common presentation to emergency room. It can be due to various reasons, cardiac reason, non-cardiac reason, neurological reason, but that is one of the most important and common presentation to ER in many patients. We will see what is syncope, what are the differential diagnoses, how do you investigate, how do you manage all these things. It's a transient loss of consciousness. So it is very important, it is only a transient, and that is due to hypoperfusion of the brain, and it is mainly due to standing posture. So three important things: it's a transient loss of consciousness due to reduced blood supply to the brain, only occurs on the standing posture. So only occurs on standing posture is correct for most of the syncopes, but there are some cardiac syncopes, they may occur in the lying down posture also. And the fourth and most important differentiating feature of syncope from other causes of LOC is the patient regains his consciousness soon after patient lying down on the ground. That is very important. It occurs during standing posture due to hypoperfusion of brain. Once the patient falls down to the ground, immediately patient regains his consciousness. And the fifth point is no post LOC confusion. So once the patient regains his consciousness, he will be fully conscious, he will not have any confusion. That is very important. Whereas in GTCS, generalized tonic-clonic seizure, some patients suddenly loses his consciousness and he will have some convulsions. But after regaining the consciousness, patient will be confused. So that is a major difference between GTCS to syncope. If the patient does not completely lose consciousness and muscle strength is reduced, that is called as pre-syncope. So many patients can have lightheadedness, they may fall, but they will not lose their consciousness. This is called as pre-syncope. So pre-syncope and syncope both should be treated in a same fashion, otherwise you may miss the diagnosis. Now, there are a lot of causes for syncope. It can be due to low peripheral resistance, that means vasodilatation in the peripheral circulation, and reduced cardiac output. Reduced cardiac output can be due to arrhythmias, both tachyarrhythmia and bradyarrhythmia can produce syncope. Tachyarrhythmia, SVT, ventricular tachycardia, and other types of atrial fibrillation or whatever it is, they also can produce arrhythmia and cardiac syncope. Bradycardia, mainly sixth sinus syndrome and complete heart block. These are the two important conditions which can produce bradycardia and cardiac syncope. Structural heart disease, there are a lot of causes you can see here: myocardial infarction, aortic stenosis, subaortic stenosis, hypertrophic obstructive cardiomyopathy, cardiac mass, especially in the atrial myxomas, pericardial tamponade, cardiomyopathies, pulmonary embolism, aortic dissection, pulmonary arterial hypertension. So all these things can produce cardiac syncope, and that is due to low cardiac output. Both low cardiac output and low peripheral circulation both together can produce orthostatic syncope or reflex syncope. Reflex syncope can be vasovagal syncope, situational syncope like cough syncope, micturition syncope, swallowing syncope, defecation syncope, like that. Carotid sinus syndrome is another important condition where the patient unknowingly stimulate the carotid during shaving or wearing shirt, putting the button in the upper part of the chest. All these things, you can slightly stimulate the carotid sinus and patient develops syncopal attack. Orthostatic syncope mainly produces volume depletion, many drugs which produces severe vasodilatation. That one of the important drug is drugs used for prostatic enlargement, alpha blockers. So they are both they can produce both reduction in the prostatic size and they can produce vasodilatation. So these drugs are mainly taken in the night time. These alpha blockers are mainly taken in the night time. So during night time, when the patient stands up, he develops severe hypotension and syncopal attacks. autonomic dysfunction, especially in diabetic autonomic neuropathy, environmental triggers like heat stroke. So there are so many causes for reduced cerebral perfusion. It can be due to low cardiac output or low peripheral resistance of circulation. Non-cardiac syncope, one of the important causes is vasovagal syncope. Vagal stimulation can occur due to various reasons. One of the most important reasons for vagal stimulation is severe pain. If the patient experience severe pain due to whatever may be the reason, it can be due to an injury to the lower limb, it can be due to a urinary stone, it can be due to myocardial infarction, it can be due to severe throbbing type of headache, whatever it is, severe pain, sudden severe pain can produce vasovagal syncope. Orthostatic syncope means when we are standing up from a sitting posture, normally BP falls slightly, but that will be compensated very fast by our heart and peripheral circulation, vasoconstriction and increased cardiac output controls that. But sometimes, especially somebody is having hypovolemia, patient is not having volume because of dehydration, diarrhea, vomiting, not taking water, whatever it may be. Hypovolemia is one of the most common cause for postural hypotension and orthostatic syncope. There are some conditions like autonomic dysfunction, especially in diabetic patients, autonomic dysfunction, and they can produce postural syncope. Postural hypotension, systolic BP may fall more than 20 mm of mercury, diastolic BP can fall more than 10 mm of mercury. So these type of patients can develop syncope while standing up from sitting posture. Carotid sinus hypersensitivity reaction is a type of syncope that occurs when the carotid sinus is slightly stimulated while putting the button, collar button or shaving. Patient can develop this type of symptoms. Post-micturition syncope, that occurs mainly during night time. Many patients complain about this because night time bladder will be full. Most of the patients will be sleeping during night time, bladder will be full. Early morning when they get up, the full bladder, they try to urinate. The full bladder, which is occupying the major part of the abdomen, now suddenly released. That means it is emptied. There will be a negative pressure forming in the abdomen that holds the blood inside the abdomen. It will create a negative pressure so that from IVC blood may not go to the heart. Okay, for some time, it's only a transient period of time. So that negative pressure holds the blood in the abdomen. So the RV and then LV is not getting adequate blood supply. So the pumping will come down. That suddenly patient can develop syncope. So these are one of the common type of syncope. So whenever patient comes in with syncope night time, we have to always ask that whether the patient had micturated just before that syncopal attack or not. So that is very important. Now postural syncope, you can see here what is the mechanism. On standing, the blood supply from the lower part of the body is already reduced, and increased sympathetic tone can actually correct it. It can produce vasoconstriction, tachycardia can occur, cardiac output increases. But in some patients, due to various reasons, it can be due to reduction in the volume, it can be due to the protective mechanisms are not working, like there is no vasoconstriction, vasodilatation is occurring there, there is no increase in heart rate, there is no good cardiac output on standing, whatever it is, the protective mechanism seen in a normal person is not seen in that type of patients. Especially this is very common in diabetic patients. Chronic diabetic patients, they develop autonomic dysfunction. The autonomic function is the normal autonomic function when we are standing up is vasoconstriction, and it will not allow the vascular compartment to collapse in the lower limbs. So if vascular compartment in the lower limb is collapsed, means there will not be any good blood return from the lower limb to the heart. All the blood will be pooling there. So that reduces the supply to the heart, that reduces the cardiac output. So it is very simple that normally when we are standing up, there will be increased vascular tone that try to remove send the blood from the lower limb to the heart, and heart also will try to compensate. There will be tachycardia, there will be increased cardiac output, all these things, the heart will try to compensate. But whereas in autonomic dysfunction, all these functions will not occur, whether you are standing or sitting, everything will be same. So suddenly when we are standing, there will be sudden vascular pooling in the lower limb, and the tone will be completely collapsed, and patient develops hypotension and shock. Now, carotid sinus hypersensitivity, we have already explained that the carotid sinus is hypersensitive. Normally, we know that when we have a patient who is having supraventricular tachycardia, we try to do the carotid sinus massage like this. Okay. When this carotid sinus is massaged, they are stimulated, and that produces bradycardia, hypotension and all. That is to control the tachycardia there. But here, while touching, as minimal touch itself can produce severe symptoms like bradycardia, hypotension, syncope, all these things are common. That is carotid sinus hypersensitivity. So that is not very common, but we have to always ask what patient was doing just before the syncopial attack, whether he was shaving or putting the button in the collar buttons for the shirt. All these things we have to ask. Now, non-cardiac syncope, post-tussive syncope. That means some patients can have, after upper respiratory or lower respiratory infection, severe cough, continuous cough, like whooping cough. You might have heard about whooping cough, continuous severe cough. During that period, the intrathoracic pressure will increase, and that prevents the venous return to the heart. So, blood can pool in the lungs. That will not give good return to the heart. So, patient develops reduced cardiac output and syncope. So, here controlling the cough itself will relieve the symptoms. Vertebrobasilar artery diseases also can produce syncope, but here it is not it should not be treated as syncope. Vertebrobasilar artery syncope should be treated as stroke itself, because normally when we get patients with vertebrobasilar artery syncope, they can have lesions in the vertebrobasilar artery. So, this will be only a warning sign for the stroke. So, we have to investigate for stroke, we have to treat for stroke, we have to prevent stroke by giving aspirin or something. Don't leave it like a regular syncope. Convulsive syncope, it's a variant of syncope, but some patients with syncope, they can have some tonic or clonic movements. We can misdiagnose it as a epilepsy. So, we have to be very careful. If the patient regains his consciousness, even if he is having a tonic or clonic jerks, we have to suspect it. We have to diagnose it as a syncope. And if you want, you can go for EEG study to rule out a seizure episode. Vasoglosopharyngeal neuralgia, that also can produce sometimes syncope. So, these conditions are very, very rare. Now, cardiac syncope can be, you can see here, it can be due to various causes. It can be due to arrhythmias and heart blocks. So, normally tachycardias, any type of tachycardia, whether it is supraventricular tachycardia, atrial fibrillation, multifocal atrial tachycardia, ventricular tachycardia, all these conditions, when the heart rate increases, the diastolic phase will come down. So, the filling of the ventricle will come down, and then the ultimate result will be pumping also will come down. So, that produces syncope. So, any type of tachycardia, patient can develop syncope, lightheadedness, pre-syncope, then syncope can occur. Same like that, if there is a severe bradycardia, like heart blocks, second degree or third degree heart block, sixth sinus syndrome, prolonged pauses can be there. Sometimes tachycardia can be there, sometimes bradycardia can be there, sometimes prolonged pause can be there. So, all this bradycardia and pause can be presented as syncopial attack. Stoke-Adams attack is a type of heart block. Both in Stoke-Adams attacks or complete heart block or second degree heart block or any other cardiac arrhythmias, even on supine posture, patient can develop syncope. That is very, very important. Most of the cardiac condition, even if it is a tachycardia, if the patient lie down, he may not develop syncope, because during that period also heart is pumping. Whereas patients who is having complete heart block or sinus pause for a long period, even the patient is lying down, heart is not pumping, so the patient can develop syncope. So there are very selected, very few conditions can produce syncope on lying down posture, that is heart blocks and this type of prolonged pause in sick sinus syndrome. So theoretically, we learned that syncope means patient develops loss of consciousness during standing and patient regains his consciousness on lying down. But in a patient who is having Stock-Adams attack, that is a complete heart block or cardiac arrhythmia which produces syncope, can occur even on lying down posture. That is very important. Now, aortic stenosis or subaortic stenosis or AETCM can produce syncope. Aortic stenosis is a fixed cardiac output. So, normal resting period patient may not have syncope, but if the patient exerts, if he walk for half an hour or if he run for half an hour, he can develop pre-syncope or syncope. AETCM is a condition where there is a dynamic obstruction. Dynamic obstruction means during exertion, the subaortic area, the thickness will be increased and it can obstruct the valve area. So that is dynamic obstruction. So in that condition also, when the patient exerts, patient can develop syncopial attack. Atrial myxoma and ball valve thrombus, that produces syncope only on selected postures. Okay, when patient is lying down or sitting up, depending on the thrombus, patient can develop obstruction of the valve and syncope. Subclavian steal syndrome, patient can develop syncope when the patient uses his upper limbs. And severe MI also can produce syncope. That is because reduced blood supply to heart, that reduces the pumping of the left ventricle, that produces syncope. And there are a lot of differential diagnoses we have discussed. You can remember it with a mnemonic that head, heart, vessels, hypoxemia, epilepsy, anxiety, brainstem disorders, heat stroke, embolism, aortic stenosis, rhythm abnormalities, tachycardia, vasovagal syncope, electrolytes, especially hyponatremia, situational syncope, subclavian steal syndrome, ENT syndromes, low systemic vascular resistance syndromes, sensitivity, carotid sinus, hypersensitivity of carotid sinus. So these are the causes you can remember like this. Now, orthostatic hypotension is one of the most common cause for syncope, whether it is due to reduced volume in the intravascular compartment or reduced cardiac output, reduced resistance in the vascular tone. All these things can produce orthostatic hypotension. By definition, orthostatic hypotension means on standing after 3 minutes, if the BP falls more than 20 millimeter of mercury in systolic BP and diastolic BP falls more than 10 millimeter of mercury, you can make a diagnosis of orthostatic hypotension. But there are many patients who may not meet the criteria, but they can have the symptoms. So whenever we get a patient, we have to always examine the BP on supine posture and make the patient stand up. Immediately you can check the BP, but after 3 minutes again check the BP, see any of the reading is dropping more than 20 millimeter of mercury in systolic and 10 millimeter of mercury in diastolic. Now, another important syndrome is POTS syndrome. Many may not be knowing about this syndrome. We all know about orthostatic hypotension, but it is not orthostatic hypotension. It is postural orthostatic tachycardia syndrome. Here what happens is, when we try to stand up from a lying down posture, the heart rate increases very fast, but there is no BP fall. So normally we check the BP on supine posture and standing posture. The BP is normal. We don't bother much. But here the problem is patient develops unusual tachycardia on standing up. So when there is tachycardia, we already know that when there is tachycardia, the perfusion can come down slowly. So that produces some lightheadedness in the patient. They don't develop syncopial attack, but they can have pre-syncopial attack. So there will be tachycardia. After tachycardia, there will be slight decrease in BP. They can have pre-syncopial attacks. So we miss the diagnosis most of the time because we will be focusing on the diagnostic criteria for orthostatic hypotension. Now, seizure and syncope difference we should know. That is because seizure, if the patient is not having a witnessed attack of seizure or syncope, we will have difficulty as an emergency doctor. We will have difficulty to make a diagnosis. So, few things we have to be very careful. One is in syncope, patient can feel the syncope. Before the syncope, patient can get an idea he is going to get some problem. He will have some lightheadedness, giddiness, vertigo-like features, and suddenly he loses consciousness. After losing his consciousness, both seizure and syncope, they may not know anything about that. But after regaining his consciousness, in seizure, patient will have post-ictal confusion. That is very important. In seizure, they can have post-ictal confusion. Whereas in syncope, they may not have any post-ictal confusion. They will be fully conscious. They will understand what has happened because it's only a transient time. Whereas in seizure, they will not be able to judge the time period between the onset of symptom to the consciousness, like regaining of consciousness time. They will not have any judgment. So that is very important. Another important investigation in emergency, this chart will help you to make a possible diagnosis of all these things, but I am not explaining this chart in detail. I am only telling two important points. One is post-ictal confusion. That is very important. Post-ictal confusion is there in seizure. It is not there in syncope. Second thing is, in emergency, you can check a lactate level. If there is a significant seizure, lactate level will be very high. Whereas in syncope, there is no elevation in lactate. So these two important things we should remember to make a diagnosis of syncope and seizure, differential diagnosis. Now, other blood investigation, we always check the blood sugar. Then ECG will be done. Treadmill can be done, or Holter monitoring can be done. Echocardiogram should be done to know what is the status of the ventricles in the heart. Then other things are orthostatic hypotension. We have to see that investigation. I'll tell afterwards. Carotid sinus massage can be tried in patient who is having carotid sinus hypersensitivity, but we have to be very careful. Sometimes this can produce severe syncope and stroke-like features. So we have to explain the patient and bystander in detail. Then we can try it. If the patient develops a pre-syncopal attack itself, we have to stop it. Holter monitoring, electrophysiology study, all these things also very important when we have no answer for syncope, because sometimes patient can have paroxysmal tachycardia syndrome. So that will be picked up only by Holter monitoring. Now this chart explains you how to evaluate a syncope in emergency room. You can read about the chart or whatever I have told in the previous slide. Same thing we are doing here in this chart also. And another important investigation which can be done in patients who is having postural orthostatic hypotension, postural orthostatic tachycardia syndrome, and postural hypotension, and patients who is having autonomic dysfunction. All these things you can do a very good investigation, that is head up tilt test. You can see here patient is lying down. The machine will tilt the patient up. Head will be up. Suddenly you can see the heart rate will be varying, like increase in heart rate more than 20% of lying down will give you a diagnosis of POTS, postural orthostatic tachycardia syndrome. If the BP falls more than expected range, you can make a diagnosis of postural hypotension. So all these things can be diagnosed by this head up tilt test. It is called as HUT test, head up tilt test. So we have discussed about various causes for syncope. Syncope is only a small portion of the diagnosis, because syncope can be seen in various conditions, cardiac condition, non-cardiac conditions, and severe stroke. So many conditions you can get syncope. So whatever I explained, that all there in the chart, you can read about this chart afterwards. So we have discussed about one of the important clinical problem which can come to emergency room. This is very common in our country, syncope. It can be due to psychological or psychiatric manifestation. Many patients come with acute syncope like episodes after some emotional attacks. So it is our duty to make out whether it's a psychiatric or psychological problem or a real problem due to some other disease. And in that, most dangerous causes are cardiac diseases, whether it is tachycardia, bradycardia, block, whatever it is. Cardiac causes are very important. Non-cardiac causes, most of the time they are benign. They will not produce any problem to the patient, but we should never miss posterior circulation stroke that mimics sometimes syncopal attack, because that can be a warning sign for the next stroke. So we have to be very careful in a syncopal attack. If the patient is having posterior circulation symptoms like vertigo, tinnitus, nystagmus, all these things, we have to be, or cerebellar findings, we have to be very careful. That can sometimes be a warning sign for next stroke. Another important thing is post syncope regaining of consciousness. If the patient regains his consciousness and there is no post LOC confusion, then it is mostly syncope. Always try to take a lactate level. You can do a lot of other investigation like blood sugar, everything, electrolytes, ECG, but always take a lactate level. If lactates are highly elevated, then it is not simple syncope. It is something else. Lactate can be elevated in a condition like, it can be elevated in seizures, it can be elevated in hypotension due to sepsis or whatever it is. So if lactates are elevated, it is not a simple syncope, and some patients may require MRI or CT scan depending on their clinical scenario. Many patients may require ECG, Holter, echo, all these things. So syncope is not a very simple problem. It can be a symptom of very dangerous disease. So we have to be very careful when we are dealing syncope. Thank you.